Hello, everyone. This is Kate Myers at the California Healthcare Foundation, and I'm pleased to welcome all of you to this webinar giving an overview of a year's worth of technical assistance activities that CHCF is pleased to be sponsoring on SB 1004 implementation. I wanted to mention before I get started with a brief introduction that this webinar is being recorded, and we will be posting it on the CHCF website within the next few days so that your colleagues who may not have been able to attend can listen in. So I'm really happy to be here with all of you today and so pleased at the amount of interest we've seen in this webinar today. CHCF, as many of you know, have been engaged in a number of ongoing efforts to support the successful implementation of SB 1004 since its passage a few years ago. We've worked with DHCS on a number of issues through that time on the process of their work in developing guidance and policies around SB 1004. And in collaboration with a number of our palliative care clinical experts and others, and we have sponsored a number of meetings mainly aimed at Medi-Cal managed care plans and also others to help all of these organizations prepare for implementation. So we're really excited to talk with you today about the opportunity that we're engaged in now to offer more structured and more intensive and smaller learning sessions and opportunities around specific topics that we see as really the important core building blocks for implementing community-based palliative care. And I'm grateful and happy to be working with Kathleen Kerr of Kerr Healthcare Analytics and Dr. Ann Kinderman of the Zuckerberg San Francisco General Hospital on this effort. Many of you know that Kathleen and Ann have been engaged with CHCF on most, if not all, of the SB 1004 technical assistance work to date. And we're really happy to be working with them over the next year or so to provide these additional intensive topic-specific resources and workshops. So with that, I will hand it over to Kathleen. Thank you.
Hey, thanks, Kate. Next slide, please. Hello, everybody. So glad that you were able to make it. So our objectives for today's hour are to begin by reviewing a little bit of general information about SB 1004, the core components and the current implementation plan, and then we'll move on to describing some of the key steps in planning for and implementing or expanding community-based palliative care services. And then we'll get into some of the details of the technical assistance services and materials that are going to be provided by CHCF over the next 15 months. Next slide, please. So I'm guessing, if you're on this call, that you have a pretty good understanding of what SB 1004 is already, but just in case, SB 1004 is a law that has been around for a couple of years, since 2014, that requires the Department of Healthcare Services to establish standards and provide technical assistance for Medi-Cal managed care plans to ensure delivery of palliative care services. And over the course of the past couple of years, as Kate mentioned, there have been a number of educational events. There have been opportunities for public comment and so on. There's a policy paper that the department developed, some resources that were prepared for several of these educational events. And all of those are available on the DHCS SB 1004 website. We've included the URL there for you to go to, but you quite frankly could also just put DHCS and SB 1004 into your favorite browser and it'll pop up with no problem. Included on that website is a policy paper which outlines the key components of SB 1004, sort of the department's approach to implementing the law. In terms of status, the governor's revised budget as of May of this year indicates that DHCS has requested allocation of funds for implementing SB 1004 in January of 2018. So all of the materials are still in draft form. The specifics of what implementation in January of 2018 means and whether or not that's the final date, that's still up in the air, but that's the best information that we have available right now. So there's been a tremendous amount of work that's already been done on this, and so I'd say that there's a pretty good idea of what this is going to look like, but we're still working with draft material. So there may still be some changes to the specifics of specific aspects of the implementation plan and the specific timing. That being said, we thought it'd be worthwhile today, just to get us all on the same page, to very briefly review some of those key components of what SB 1004 will look like once it's implemented. Next slide, please. So to begin with, the target patient population, the eligibility criteria, and there's two aspects to this. There's general criteria, criteria that have to be met for any individual regardless of diagnosis. One, that they are likely to or have started to use the hospital or the emergency department as a means to manage his or her late-stage illness, so they're clearly in need of some additional support. Documented late-stage illness with declining health status, and the individual is not eligible for or declines hospice enrollment. And then a version of the surprise question where death within a year would not be unexpected based on clinical status. Next slide, please. Also, that the patient has received appropriate patient-desired medical therapy, and really that the patient is not in reversible acute decompensation, and that the beneficiary, and if applicable, the patient and family have agreed to attempt in-home residential-based or outpatient disease management instead of first going to the emergency department, and that they are open to participating in advanced care planning discussions. Next slide, please. And then in addition to those general criteria, there are the bill targets 4 specific disease groups, and there are disease-specific criteria as well. So for CHF, congestive heart failure, the individual would have been hospitalized for CHF with no invasive interventions planned, or they meet criteria for New York Heart Association heart failure class 3 or higher, and they have an EF of less than 30 or significant comorbidities. For COPD, another of the targeted disease groups, you need to have an FEV1 of less than 35% predicted, and an O2 requirement of less than 3 liters, or having a 24-hour O2 requirement of greater than 3 liters per minute. Next slide, please. For advanced cancer, the target population are individuals with stage 3 or 4 solid organ cancer, lymphoma or leukemia, and a Karnofsky performance scale score of less than 70, or failure of 2 lines of standard chemotherapy. And finally, for liver disease, evidence of irreversible liver damage with some accompanying lab values, evidence of some significant symptom or comorbidities, and or evidence of irreversible liver damage. So there's a more exhaustive description of these target populations available in the policy document and also in a draft all-plan letter that was distributed last year. I think the big take-home message here is that these folks are really, really sick, and also that you're going to probably need to use a combination of claims-based and records-based criteria in order to identify these individuals. Next slide, please. So once you determine that an individual is eligible for SB 1004 or Medi-Cal palliative care, there are a set of required services that would need to be made available to them. Again, there's a very nice description of these services in the policy document that's available on the SB 1004 website. But briefly, you would need to be providing advanced care planning support and assistance with completion of appropriate documents that memorialize patient and family preferences. You would need to be providing palliative care assessment and consultation, which would focus on everything from treatment plans, including treatments directed at palliative care and curative care, attention to the presence of pain and other symptoms, medication side effects, emotional and social challenges, spiritual concerns, patient goals, advanced directives, including pulse forms. So that's what your assessment and consultation work would focus on. You need to assist individuals with developing and updating a plan of care and making sure that's appropriately implemented. You need to provide care coordination support. You need to attend to pain and symptom management. You need to ensure that individuals have access to the appropriate mental health and medical social services that they need in order to maximize quality of life and attend to the full range of of their needs, and you need to ensure access to chaplain services for spiritual support. And then it's recommended that you also develop a mechanism so that individuals have 24/7 telephonic support. And really that's a great mechanism for ensuring that folks don't have to use the emergency room instead of agreeing to home-based disease management. So next slide, please. Another key component of the draft all-plan letter that came out, in addition to specifying the target population and the required services, is there was a presentation of some draft plan deliverables. So what the health plans would need to have in place prior to implementation of SB 1004, and we tried to be mindful of these in developing the technical assistance materials. So plans would need to have policies and procedures in place that address the process that the plan will utilize to inform and educate providers about the availability of palliative care, and we will be addressing that in the technical assistance materials. You need to have policies and procedures in place that specify the eligibility criteria for the providers and helping them to identify beneficiaries eligible for palliative care and to figure out a provider referral process. And again, that's something that we'll have a go at supporting you with through our technical assistance offerings. The third deliverable was the process that the plan will use to address disputes related to the provision of palliative care consistent with current grievance and appeals requirements. We will not be addressing that. We figure you all know your business best there, and the process used for palliative care would not be radically different from processes that you're using for other benefits. And finally, the method that the plan will use to monitor and collect palliative care enrollment and utilization data. And it's noted that the plan will have to report palliative care data to the department on a quarterly basis and upon request. And we will also, in our technical assistance, get at this issue of metrics and monitoring and so on. So those are some of the core elements of SB 1004 as we currently understand it. And as I said, the expected implementation date is currently is January of 2018. Next slide, please. So that does beg the question a bit of why offer technical assistance now? Well, the big reason is that this really takes a lot longer than you'd think it would to attend to all the specifics that need to be attended to in order to go from an intent to ensure access to palliative care to actually having everything in place so that it can be delivered. We've been working for the past 2.5 years with a group of payer-provider partners through a related CHCF initiative aimed at increasing access to palliative care. And even after 2.5 years, there are still quite a few issues that these teams are working through. It is hard to do, it's complex work, it's a new type of service delivery, and so it's never too soon to start planning and going through some pretty predictable tasks that need to be accomplished in order to get palliative care access in place. We know that this is a process. We also know that all of you, be you a health plan or a provider group, are likely sitting on different points along the continuum of thinking about starting to make sure that palliative care is available or thinking about starting to deliver palliative care, all the way through to we're already offering something that pretty much covers all of these required elements, we're good to go. And most of you, I think, are at some point along that continuum. We also know that even though some aspects of SB 1004 might change between now and when it's actually implemented, there are going to be some areas where you almost certainly need to focus your attention, even if some of the specifics of SB 1004 get changed a bit. You're going to need to think about the palliative care workforce, what's in place and what more do you need to develop in order to meet the needs of your beneficiaries and patients. You need to work on relationships with other network providers to ensure patient identification and appropriate referrals. You need to work on your approach to patient education so they know what palliative care is and are open to receiving these valuable supports. And you're almost all going to need to be focused on data collection and the work that needs to be done to ensure your ability to track metrics and know if the programs that you're offering are having the impact that you expect. Next slide, please. So what we've done is based upon our learnings from other CHCF initiatives, the information that was gathered in prior SB 1004 educational and technical assistance offerings, and the information that's in the current description of what SB 1004 is likely to look at, we've identified 5 sort of building blocks for implementing community-based palliative care, and these will be the focus of the technical assistance offerings that will be taking place over the course of the next 15 months. So the first topic is estimating the number of individuals who would likely benefit from or qualify for SB 1004 palliative care, and also their baseline utilization patterns. So how are these folks currently engaging with the healthcare system? Understanding that information, generating that information, will be really important to your planning process, and down the road it will be really important to your assessment process. The next building block is estimating costs for delivering services, and this is one that's really of keen interest to the providers there who would be engaged to deliver palliative care services. What exactly will it cost my organization to deliver these services to a specific population? And you'll need to know that in order to engage appropriately with the plans that are looking to make sure that these services are available. The next is evaluating current capacity for palliative care within an organization or in a given region. So whether you're a plan or a medical group or network that has delegated responsibility for ensuring access to palliative care, you need to know, what do you already have in place? How much palliative care could you already deliver, and how does that compare to your estimate of how many folks are likely to need it? The next is developing a strategy to expand services. So what you need to do to bridge that gap between current capacity and estimated need. And the final building block is gauging and promoting sustainability and success. And this is everything from defining success, selecting metrics, engaging in a quality improvement and assessment activity, and the things that you need to do to move from a pilot program to a service that's sustainable. Next slide, please. So for each of those core topics, we'll be delivering sort of a package of technical assistance. We'll begin by offering an introductory webinar, and those like this webinar will be recorded and posted to a dedicated website within the larger CHCF website. And in those webinars, we'll cover core concepts, so the things that you would just sort of generally want to know, and really also prepare you for the next technical assistance support, which is an in-person small group meetings. And here we'll hold meetings, at least one in Northern California and at least one in Southern California. These will range from 2 to 4 hours in length, depending upon the topic, where some small number of groups, and it'll vary according to the topic, anywhere from 3 to 6 and maybe a bit higher. We're still working that out. We'll come together and spend some time really getting into the details of what the specifics of the tasks related to each of the 5 core topics. It's a chance for you to engage different folks within your organizations who would be interested in different topics, and to really very practically, through the use of worksheets and action plans and so on, move along that path to actually completing the work appropriate to that topic. And then finally, after the in-person sessions, we'll take those, the lesson plans, if you will, related to the work that we did in the in-person meetings, translate those into guides and durable materials, and post them onto the website so that folks can access them at any time and address this material at their own pace. Now, in terms of the in-person sessions, we will hold at least one in Northern California and one in Southern California for each topic. If there's a whole bunch of interest in a particular topic, we could expand that to having more than one. It'll really depend upon what the demand is like. Something else I should mention is that all of this stuff is free. Yay, my favorite cost. So you'll need to get yourself to these in-person sessions and get yourself to the webinars and so on, but there will be no cost to access any of these services or materials. I guess I should also say that the in-person sessions, and then also the webinar content and the online resources will be developed not only by Ann and myself, but we'll also pull in individuals, guest faculty and co-developers who've had some experience in doing the work related to that topic themselves. So organizations that are further along, relatively speaking, on the path for delivering or paying for community-based palliative care. Next slide, please. So a little bit more on how the content is being developed. We're really pulling in, we're trying to be very, very practical and real-world based in this. We're pulling on the lessons learned and the practices that we've seen being used by well-established payer-provider partnerships that are folks who are currently offering palliative care. And these are things that we've seen through a variety of CHCF initiatives that have been held over the course of the past couple of years, and also our experience working with other organizations. We're developing them, as I said, in partnership with folks who are actually doing this work, and in all of our materials, in the webinars, in the in-person workshops, and in the materials that will be posted on the website, we'll highlight additional resources that you can go to learn more or get additional support. So, for example, appropriate educational sessions that are offered through, say, the CSU Institute of Palliative Care, materials that might have been developed by and available through the Center to Advance Palliative Care, and so on. Next slide, please. So what we'd like to do now is just spend a little bit of time talking about the specifics of each of the topics, so what you might expect to learn about if you tune into a webinar or come to an in-person session. The first topic, estimating the number of eligible members and baseline utilization patterns. This table that's on the slide is actually pulled from a utilization analysis that was done by the folks at DHCS, looking at the proportion of individuals who, in a decedent population, who had the 4 diseases of interest for SB 1004. And they looked at this for all California decedents, all Medi-Cal beneficiaries, and then for Medi-Cal, looking at a subset of distribution across dually eligible individuals and Medi-Cal only individuals. And you can see that there's some differences there depending upon contrasting, for example, Medi-Cal only to all California decedents. And you can imagine just how important it is to know, well, how many folks are we talking about? And not only that, but not only how many people might be eligible for SB 1004, but how are they currently engaging with the healthcare system? How often are they hospitalized? How often are they going to the emergency department? Where are they receiving care generally, so that you might that might help to inform your plans about doing provider outreach, patient education, where you might want to embed some specialty palliative care services, and so on. So we thought that this was a very natural first topic to cover. Next slide, please. So the specific objectives for this topic are to explore strategies for estimating the number of patients and members who would qualify for SB 1004. And this is going to vary a bit program to program, depending upon the data that you have access to and the quality of that data and your options for navigating those differences between the information items that are accessible to you through claims data and the information items that would only, say, be available in a medical record. We'll review a method for appreciating baseline utilization patterns in the final year of life among eligible patients and members, so that you can anchor your understanding of what baseline costs and utilizations look like, so that you can prepare yourself to assess the impact of your program. We'll include some case studies looking at how other groups have gone about this work of both estimating the number of palliative care appropriate individuals and looking at what their baseline costs and utilization patterns look like. And then we'll spend time talking about local data sources, so what information is available to you and who from within your organization might be involved in tackling this work. Next slide, please. So who should attend? Who might be interested in this webinar or coming to the in-person session? This is really a topic that's pertinent to the Medi-Cal managed care plans or the delegated groups that are responsible for delivering care. They would have the necessary data about the enrollee, their patients or their beneficiaries, and how those folks are accessing the healthcare system currently. And this is really kind of a team sport. You would need an individual who has understanding of the data systems and what data are available, but you'd also need input from someone with clinical expertise, so an understanding of which variables mean what in terms of clinical information and healthcare utilization for the identified population. So we'd recommend that you have a data person and a clinical leader or an administrator with clinical knowledge come as a team to the in-person session or listen in on the webinar. We do have dates scheduled for this first topic. The webinar will take place on July 18th from 12 to 1, and we'll be distributing through email an invite to that if you're interested in registering. The in-person sessions, the Northern California session, will be held in Oakland at the CHCF offices, and that will happen on August 17th. The Southern California session will be held in Los Angeles, I believe, at the offices of the California Endowment, and that'll be held on August 15th. And then the self-guided materials will be released in September of 2017. Next slide, please. So topic number 2, estimating the cost of care delivery. So topic number 1 was really focused on some information that's super critical both to the plans and to the delegated networks and medical groups. This next topic is of critical importance to the provider groups, those individuals who are looking to potentially partner with the plans or a network to deliver palliative care services. And obviously, if you want to enter into a discussion about, hey, could we meet this need for you, you need to have an appreciation of what your particular costs would be. So SB 1004, that the elements that have been described in the policy document and the all-plan letter, they talk quite a bit about sort of the what. So who are the patients, what are the required services, but they don't really get into the specifics of exactly what clinical model will you use, exactly which team members will do what. And they certainly don't know about the number of patients. And there's a whole array of variables that you would need to consider as you're modeling the expected cost of delivering care, none of which is in, or most of which is not specified in the SB 1004 policy document or all plan letter. These are things that you would need to negotiate with an engaged plan to work out. So you need to think about how many patients would we be talking about. For our program, which specific team members would be involved and which activities would each of those team members carry out. What are the care settings that you are delivering services in? Is it home-based only, or might some of the work be done in a clinic or office-based setting? Will you be using video visits or phone support to deliver a portion of the care? What is the expected number of visits per patient? And how long might you expect to engage with these patients? What other supports are available in your area or from within a network that can help to meet the palliative care needs of patients? What's your geography? Are you in the heart of Los Angeles, or are you in a rural area? And then also your particular organization's administrative and indirect costs. And so you'll need to think about all of these things in the setting of the specific services that are required by in SB 1004 in order to model your costs. Next slide, please. So the specific objectives for this topic are to review various service delivery models, so appreciate the different methods that you could use to get those essential services delivered to the eligible patients. And then to think about how those different service models will influence the cost of care delivery. And that would include both variables related to direct patient care as well as indirect and administrative variables. And then pulling on some of the lessons learned from prior CHCF initiatives, we'll also share with you things that we've seen folks use to help them mitigate some of the risk and uncertainty that comes with launching a new program. So how have other payers and providers work through the process of maybe not being entirely sure of how much service an individual patient is likely to need, and how might you protect, for example, a very small hospice that's looking to deliver some of this care from some really unexpectedly high costs of care delivery, while they're still sort of maybe working through the exact features of a more post-pilot payment model, for example. And then finally, we'll spend some time here thinking through promising practices for developing positive payer-provider relationships. It's a lesson that's come through multiple times and very strongly, and work that we've done in other initiatives, that the success of a program, nearly every aspect of it is anchored in having a positive relationship between the payer and the provider. And we can talk a little bit about what both payers and providers have said about that, and share some of their thoughts about things that you could do right from the beginning to help to maximize the odds that you'll be successful in this. So with that, I will hand it over to Ann Kinderman to talk about the final 3 topics and then take us home.
Great, thanks Kathleen. Glenda, could you advance a couple slides further? Okay, great. So the third topic that we're going to be looking at is looking at your current network or your group capacity to provide palliative care. So what is in existence now, so that you have a sense of where you need to go, where the gap is between what you're doing currently and what you need to provide based on the work that's done in particularly topic number 1. If you can advance, Glenda. So the world of palliative care services has really taken off exponentially, particularly when it comes to community-based palliative care delivery. You could advance. So if you look on the left side of this, there are kind of 3 major approaches to providing specialty palliative care in the community. There are a number of programs that are now delivering home-based services, so similar to home health agencies or hospice agencies that are delivering in-home, mostly hospice-type care that's concurrent with disease-modifying therapies. There are more and more programs that are now starting to provide telehealth palliative care, which really helps to address the issues of transportation, particularly relevant in the Medi-Cal population, where oftentimes there's not a lot of funding for transportation to lots of visits, or they're in rural areas where it's hard to get to their providers. And lastly, there are a number of clinic-based palliative care programs usually launched out of hospitals or health systems. So you need to figure out about who in your area is delivering specialty palliative care. And then on the right side of this, you see this bubble that says primary palliative care, which may be a new idea for many on the call and can be a bit confusing, but it's the idea that all kind of frontline providers who are taking care of people who have serious illness need to have some at least basic primary skills in palliative care around communication, symptom management, prognostication, and planning. And so we need to figure out who is already doing this work kind of in a dedicated way, so that we have an understanding of really the full picture of who's delivering palliative care in your area. Next slide. The objectives for this session are to look at the strategies to identify the specialty palliative care services available in your area. And this is important because you may think you know who's there, but it's a really rapidly evolving landscape, both in terms of the new programs that are popping up all the time and also the organizations that haven't been able to sustain themselves. So finding out who currently is providing specialty palliative care services. We'll dig in a little bit more into what this primary palliative care means and talk about the role of non-specialist providers in delivering palliative care. We'll talk about what are the conditions and supports that you need to deliver these SB 1004 defined services. As an example, it's the advanced care planning services that are required. I hear a lot of times from frontline providers that they recognize the importance of advanced care planning, but since it's not a performance measure in the same way that other things are, say, for diabetes, that it's really hard for them to take the time to prioritize it. So we're going to dig into what are the things that are needed to create the conditions to deliver these services. We'll also outline some approaches to assessing your capacity of local palliative care providers, both primary and specialty palliative care, to deliver the services. So what are they doing right now, and how much can they flex up to take on more patients, to expand? And then lastly, we'll help each group to develop a summary of the gaps between what is available right now and what is needed to meet the mandates under SB 1004. Next slide. The folks who we think would be great to attend to these webinars or the in-person sessions, it's really a combination of both representatives from specialty palliative care providers and the managed care plan or delegated group. From the palliative care side, we think that folks who have access to program outcomes data and those who are really thinking about program planning and where the program is headed would be great to have involved in this. And from the managed care plans, the folks who are really familiar with the clinical activities of the affiliated medical groups and community programs, what are they doing as it relates to the required services under SB 1004? As you can see, this topic is going to be covered between December 2017 and February 2018. Next slide. All right, so topic 4 really starts to bring everything together. So the first 3 topics really help to define the need and where you need to go, what space you're leaping to, and then where you're at right now, where you're coming from. And so the idea is that this is, potentially going to be a little bit of a leap, but hopefully we can make that as painless and as thought out as possible before you have to do that. Next slide. The objectives for this session are to look at different mechanisms to expand your capacity to provide palliative care. Is this something that you're going to build internally from scratch, or are you maybe going to delegate this, buy these services from another organization, or are you going to train up your existing workforce? There are pros and cons to all those different approaches. We're going to provide some examples of referral processes for the managed care plans who have existing palliative care programs, what we've learned from folks who are kind of on the front end of this. We're going to look at different strategies to identify members eligible for SB 1004 palliative care. As Kathleen alluded to, oftentimes this involves a combination or collaboration between the plan or the folks who have the claims data that look at who might be eligible, and then with the providers who have the clinical information looking at who actually meets the disease-specific and general eligibility criteria. We're going to describe outreach and educational initiatives to help assist the frontline providers in identifying the eligible patients, which will also feed into that requirement for the plans to outline that strategy. And we're going to look at the process for piloting and then refining that referral process, and then help bring all of that together and summarize those practices into your policy documents for CHCF. Next slide. The folks who should attend, again, it's really helpful to have a combination of folks from your palliative care group who are responsible for program planning, and folks from the managed care plan or delegated group who have responsibility for developing a strategy to cover new benefits. These are things that we've done before in lots of other areas, so leveraging that expertise. And then the individuals who really know about the care delivery operations as you're implementing these new strategies. So this series is going to happen between March and May of 2018. Next slide, please. So quickly, the last topic that we're going to be talking about is really thinking about how to assess and then sustain your palliative care program. It's important because, as I mentioned, there are programs that do great work and get off the ground but have a hard time continuing on for a variety of reasons. And things that you need to look at to ensure that these programs don't just get started but really are sustained and ideally scaled is to think about what the impact is on the organization or system costs. What are the costs that you might be avoiding when you look at the utilization patterns of patients who get palliative care versus those who don't? What are you saving? And then what are the program costs? How do they compare to what was predicted? You also need to think about how the program is impacting your quality measures. How does this impact the patients and families who get the services? And then for your quality measures, how is the program impacting the things that you're looking at and reporting on for certifying bodies? And then it's really important as this collaboration goes on, as Kathleen mentioned, it's an iterative process where you often need to make adjustments to those initial ideas about how your referral processes are going to work, how you identify patients, and how care is delivered. Next slide, please. The objectives for the session are to look at the information from DHCS about the initial program evaluation and reporting, which hopefully by the time we're looking at this topic, we'll have more clarity on that. We're going to look at the current resources that are available to measure palliative care quality, all the various national entities, and frankly, large number of measures that you could consider looking at. And we'll help you to identify things that are relevant, particularly for review locally, because everyone has kind of different priorities. We'll look at the process steps to select those quality metrics, and then create processes for routine program review and quality assessment. We'll look at the key factors that promote program sustainability and enable scaling of services, really, again, pulling from examples of programs who have already been doing this and pass on lessons learned. And then lastly, we'll talk about how palliative care gets integrated into other system or plan or regional services so that you're not just providing things in silos, but it's really all pulled together in a coordinated and efficient way. Next slide. This last session also is, I think, will be best if it's, we have a combination of folks from the palliative care providers who have experience in analyzing program data and planning for the future, as well as folks from the managed care plan or delegated group who have experience in quality assurance and looking at finances. This is going to be, so our last topic will be in the summer of 2018, and will really help to continue on in the work as SB 1004 continues to grow and evolve. Next slide. So really by the end of the series, we're really hoping that you will have a detailed strategy for accomplishing all of these key tasks to prepare for and implement or expand your existing palliative care services, and so that you'll be able to meet the mandates of SB 1004. Next slide. As a reminder, this is our structure where we're going to have webinars for each of the topics, in-person meetings. Just to give you an idea of this, our goal is that we have at least a couple of people from each of the topics. So if you're a provider, delegated group, or managed care plan partnering with someone from palliative care, having people to work together in this at the in-person meetings really will be ideal. Our attendance, tentatively, we're looking at 4 to maybe 6 groups, somewhat limited by the size of the rooms that we'll have. But as Kathleen mentioned, we really want to be as flexible and attentive to the interest as possible. So if it seems like there are more people either in Northern California or Southern California who are interested in attending an in-person meeting, we will do our best to develop a waiting list and try to expand to additional sessions if needed. We're also, we'll hope to be available for questions as folks may be working through the self-guided materials. If there are a lot of questions that end up coming up, we may explore doing office hours calls or other things to address those questions in a group fashion. Next slide. So this is looking really the big picture timeline of our technical assistance series. Topic 1 is going to be really through the summer and into early fall. Topic 2 will be in this fall from September to November. Topic 3 going from December to February 2018. Topic 4 from March to May, and then lastly wrapping up with topic 5 into next summer. Next slide. In terms of next steps, we're hoping that following this webinar, you will not only think about your own interest in this topic, but also who are the folks that you know who might be interested in or benefit from this technical assistance series, and share this information with them. There'll be a variety of ways. Either you can pass this along individually or help identify them to us in the survey we'll be sending. It would be great if after this webinar you could look at the topics in greater detail with the folks you're going to be partnering with, and think about which ones are the most interest to you right now. For some of the groups that are on the call, you may have already tackled some of these topics, and you don't need to spend as much time on them. For others, you may be very early on in the process of thinking about developing palliative care services for SB 1004, and you might be interested in all of them. So we recognize that and know that there will be variable interest in the 5 topics. So what you can expect in follow-up is you'll get a survey to help you report on your interest in these different topics, and we'll give you space to actually talk about which of the objectives are of most interest to you and what things might we have missed in each of these topics that you would like to know more about. You'll get email invitations about the individual webinars for each topic, and then signing up for the in-person meetings. And as Kathleen mentioned, we'll have a dedicated location on the CHCF website for the series materials. If you have questions following the webinar about the, our technical assistance series, the best person to contact for that is Glenda, who is our contact at the CHCF. And we here are listing the website or the email address of the folks at the Department of Healthcare Services who are working on SB 1004 policy. Next slide. With that, we'd really like to open this up for about the next 10 to 12 minutes for any questions that folks on the call might have.
Thanks so much, Ann and Kathleen. This is Kate Myers again. And just so people are aware, there's a few ways to ask questions. If you want to speak and voice your own question, you can use the raise my hand function, and Glenda can unmute your line when we get to that. If you prefer to type a question into the question box, you can go ahead and do that. We've had a couple questions roll in while Kathleen and Ann were presenting, so I'll start with that while others take the time to type in a question or raise their hand. So the first I can just respond to quickly. There were a couple folks who asked if we had dates for future topics, for example, topic 2 or some of the other subsequent topics. And we don't have those precise dates scheduled for the webinars or workshops yet, but we do have the months identified, as was pointed out in the workflow plan. But we will publicize the dates for future topics as soon as they are scheduled. And we know people need time to plan in advance, but we're working on a few different schedules around sites and availability of our faculty. So we'll get that out there as soon as we can. And then a couple questions came in that either Kathleen or Ann, I'd like you to respond to. There were a couple comments around the fact that the timeline for this technical assistance series doesn't exactly line up with the new implementation date for SB 1004. So there were a couple questions around the idea of, are there any possibilities of changing the dates, or can you describe a little bit about your perspective on the differences in those timelines?
This is Kathleen. I'll have a go at that. The timeline for this project was developed when the scheduled launch date for the revised scheduled launch date for SB 1004 had been set at July of 2018, and that has been moved up, which is terrific. But it's just not quite possible to cut in half the time it takes to develop and deliver these topics. And we do realize that some of them are slated to be launched after January 1st, 2018. And there's a couple things I'd say about that. One, we don't know yet exactly what implemented by January 2018 means, so it may be that might not matter. The other thing I'd say is that this is going to, for some of the plans or some of the groups that are really just beginning, this is going to take as long, probably through the entire time that it takes to develop the series, to go from beginning to think about how many eligible patients there are through actually having services up and running and ready to be delivered. So we expect that they'll still be at least doing that in a very complete and thoughtful and evolved sort of way. So we expect that there'll still be interest in and a need for this type of technical assistance, even if you've already begun delivering palliative care in January of 2018. Anne, do you have anything you want to add to that?
Yeah, I think agree with all of that, and I think what I would add is that you know, the California Healthcare Foundation has already done, you know, some good amount of technical assistance work in things that are going to be addressed in more depth, but have already been touched on in previous stakeholder meetings, such as strategies to expand your services, and whether you want to build those on your own, whether you want to contract out for those services or train up your existing provider workforce. So there are resources that are available for that you can already start looking into. But yeah, just I think I agree with Kathleen in as someone who is on the provider side of developing palliative care programs, it does take quite a bit of time to do that, and it's hard. We recognize that folks who have already looked at the need and their the costs already, who want to really dive into the expansion strategy, you know, I know it may be hard to wait for a little while, but for folks who are really starting from scratch, they're not able to jump to that spot just yet.
Thank you both. And another attendee commented through the question function that, and actually some of the later topics do lend themselves fairly well to consideration after, you know, implementation has already started. So hopefully there'll be some synergies realized there. There was a quick question which I'll just respond to. Again, there was a question about slides and recording of the webinar. We will be providing both the slides and a recording of the webinar on the CHCF website, and you'll all receive an email when those are posted. So thank you for that question. There was another question which I can also respond to. Do you know when the final all-plan letter will be released from DHCS? This person has only seen draft versions, and we do not have that information from DHCS. So I'm sorry, I can't provide more guidance there. There was another question that I'm not entirely sure what they're referring to, but maybe Kathleen and Ann, this will make more sense to you. Someone asked, when will you provide a template of the data you will request from the health plans? So I'm not sure which topic issue that might have been in reference to.
I'm guessing that is a question regarding what the DHCS will be requiring the plans to report.
I see.
And and so that's a fantastic question. And again, unfortunately, one we do not have a lot of specific information from DHCS on. I know that they're still thinking about this, and they, you know, try to mention in talking about topic 5 is there's really a lot to think about in terms of measuring your success. What we've heard so far is that these requirements are in the beginning likely to be not as stringent, kind of from reporting on your activity, and then may evolve to add additional kind of quality measures down the road.
Thank you. Are there any other questions, or Glenda, are there any hands raised that you'd like to unmute lines for?
I do not see any raised hands.
Okay, we'll give another minute or two for anyone else to type in any additional questions. And I just wanted to ask one sort of summary question. You both addressed this a bit during your comments, but I think it's a nice thing to wrap up on. Given the variety of kind of stages of readiness different organizations are at with SB 1004, can you just say a few more words about what you see as really the range of ways that different people in different organizations can engage with these resources in terms of engaging, you know, in all the topics, or dipping in and out, or doing some things virtually and some things in person? Is there anything more that you'd like to describe about how you envision this playing out for organizations at different stages of readiness?
I think, Kathleen, if there's anything you want to add beyond what I said towards the end of the session?
Yeah, no, I think that we were, I think a lot of it is probably driven by just the preferences, and then quite frankly availability of the folks who would be doing the work. I think that we're trying to release this in a way that will accommodate all sorts of preferences. So if you feel, if you like to sort of listen to a webinar and then have a go at things on your own, then you should be able to do that by listening to a webinar recording or going to the live session and then pulling from the resources that will be posted to the website. I guess one thing I would say is that what we've witnessed is that it's been incredibly useful for to have sort of scheduled time where a payer representative and a provider organization representative can come together to have some dedicated time in a semi-structured environment to start to work through some of these topics. So I'd say that for topics 3, 4, and 5, being able to go to an in-person session and work on some things together is probably going to be super valuable. And then, of course, if you, for timing purposes or whatever reason, that's not possible for you, then you obviously want to just sort of hold those sorts of sessions on your own. So, no, you know, I think people can, I expect that there's some folks who may think they don't need topic 1 or 2 or 3, but then they might realize after they go to topic 4 session that, whoops, we kind of need to go back and have a look at those. So, yeah, I think it's flexible, and we're hopeful that that you guys will find the method of learning and support that best suits your circumstances and preferences.
Great, thank you both. I'll do one last check. Glenda, any raised hands?
No.
Okay, and I don't see any additional questions in the question box, so just a couple minutes early here. I want to thank Kathleen and Ann so much for their time today, and thank all of you for your interest, and hope you'll engage with us on this journey over the next year to continue to increase all our organizations' readiness to succeed in the implementation with SB 1004. So with that, we will close today's webinar, but again, you'll receive information by email, including the follow-up survey and including information about the webinar recording and slides, so keep an eye out for that. And we look forward to your responses to the surveys to help guide our planning for each of these topic sessions. Thanks so much, everyone.
Thanks.